Welcome back, everyone. As a clinical documentation improvement, or CDI specialist, I am absolutely thrilled to kick off part 3 of our 15-part masterclass series. Today, we are focusing our explainer entirely on decoding the complexities of SIRS for clinical validation. We're going to break down the diagnostic criteria, explore non-infectious insults, and really arm you with exactly what you need to ensure accurate, audit-proof medical coding. If you're a coder, a CDI specialist, or an auditor, mastering this topic is absolutely foundational for your day-to-day work.
So right out of the gate, let me ask you this. Is it a sterile response or is it an active infection? This right here is the #1 challenge that auditors and coders face when reviewing a patient's chart that shows signs of systemic inflammation. You look at the vitals, you see the red flags, and you have to ask yourself, what is the underlying cause here? Getting this wrong doesn't just lead to clinical confusion, it literally leads to massive coding denials and compliance risks.
Okay, let's dive into this. Today's roadmap covers an introduction to SIRS, the non-infectious triggers, those 4 crucial parameters, CSI, and chart validation, and we'll wrap up with a summary and some next tips. All right, Section 1, an introduction to SIRS, or as I like to call it, the body's alarm bell. To really understand SIRS, we have to start by looking at inflammation, which is the body's natural alarm bell against harm. Based on our source material, SIRS stands for Systemic Inflammatory Response Syndrome. According to the clinical guidelines, it's defined as a systemic host response to a non-infectious process or insult. Now, I want to heavily emphasize that word, non-infectious. This is the absolute critical distinction. It's exactly what separates sterile SIRS from a condition like sepsis. The body is in a state of high alert. It's throwing a massive inflammatory response. But there's no bacteria, no virus, no infectious bug driving it. It is entirely a sterile insult.
Moving right along to Section 2, the triggers and non-infectious insults.
So, for all you coders and CDI professionals out there, what exactly are you looking for in the physician's documentation when you spot systemic inflammation? Well, our source documentation outlines a very clear list of these sterile contributing factors. We're looking at things like severe physical trauma or major surgeries. Think of extensive burns across the body, or acute internal conditions like acute pancreatitis and acute mesenteric ischemia. It can even be triggered by malignancies, a myocardial infarction, a heart attack, chemical aspiration, chemical peritonitis, adverse effects from medications, and even blood transfusion reactions. Every single one of these is a major physical trauma or sterile insult that essentially forces the body to hit the systemic panic button. When auditing a chart, if you see SIRS documented, you absolutely must look for one of these non-infectious processes as the root cause.
Which brings us to Section 3, the 4 SIRS parameters. These are your objective thresholds. Consider this your definitive playbook for objective chart validation. You see, you can't just guess that a patient has SIRS. The actual numbers in the chart have to prove it. And to prove it, we use what I like to call the rule of 2. The clinical documentation must support at least 2 out of the 4 parameters we're about to look at running alongside that documented non-infectious process. If a physician writes down SIRS, but the vitals and labs don't meet at least 2 of these specific thresholds, well, you've got a clinical validation query on your hands, for sure.
Now, what's really interesting about these metrics is just how precise they are. Let's walk through this cheat sheet methodically. First up, temperature. We're looking for hyperthermia over 38 degrees Celsius, that's 100.4 degrees Fahrenheit, or hypothermia dropping below 36 degrees Celsius, which is 96.8 Fahrenheit. Second, heart rate. We need to see tachycardia, meaning a heart rate strictly greater than 90 beats per minute. Third, respiratory rate or blood gas. Tachypnea, meaning breathing faster than 20 breaths per minute, or an arterial CO2 level of less than 32 millimeters of mercury. And finally, the white blood cell count. We need to see leukocytosis, which is a WBC greater than 12,000, or leukopenia, a WBC less than 4,000. Remember the rule of 2. You need at least 2 of these 4 objective data points clearly documented in the chart to validate that SIRS diagnosis.
All right, Section 4, CDI and chart validation. This is where the clinical theory we just discussed meets real-world chart interpretation and coding guidelines. We have to draw a sharp, undeniable contrast here. Sterile SIRS is a systemic response specifically tied to a non-infectious insult, like a burn or major trauma. On the flip side, infectious sepsis, especially under the Sepsis 3 consensus definition adopted back in 2016 by the Surviving Sepsis Campaign, is defined as life-threatening organ dysfunction due to a confirmed or suspected infection. Actually, Sepsis 3 completely discarded the older concept of sepsis as SARS due to infection. So today, SARS remains highly relevant, but specifically for those non-infectious insults. Mixing up sterile SARS with infectious sepsis is a massive pain point in the coding world, and I promise you, it's a fast track to coding denials.
The coding guidelines give us very strict instructions on how to handle these overlapping scenarios. Let's read the sequencing rule directly from the official guidance. If a non-infectious condition, such as a burn or serious injury, meets the definition for principal diagnosis, the code for the non-infectious condition should be sequenced first, followed by the code for the resulting infection. As a CDI educator, I literally cannot stress this enough. Accurate principal diagnosis assignment dictates the entire narrative of the patient's hospital stay. If the burn is the main driver, it goes first.
But, there is a really important caveat here that you need to be aware of. The guidelines also state that when both the associated non-infectious condition and the infection meet the definition of principal diagnosis, either may be assigned as the principal diagnosis. This means you, as the CDI specialist or coder, must look really closely at the circumstances and the true focus of the admission. What was the primary resource driver? What was the physician's main focus of treatment? That focus, right there, is what will dictate your final sequencing.
Finally, Section 5. Let's summarize and talk about next steps.
So the crucial point is really this simple three-step workflow, and I want you to cement this into your daily auditing routine. Step 1, always identify the explicit non-infectious insult in the chart, whether that's pancreatitis, a major trauma, or a burn. Step 2, clinically validate that diagnosis by confirming at least 2 out of the 4 SIRS vital and lab parameters are actually met. And Step 3, apply the coding guidelines to sequence accurately based on the principal reason for admission. If you follow these 3 steps, your documentation is going to be bulletproof.
I want to leave you with one final provocative thought to take back to your teams. I challenge you to look at your own facility's documentation standards and ask, does your clinical documentation clearly separate the sterile insult from an infectious threat? If the answer is no, or even just sometimes, then you know exactly where your CDI efforts need to be focused next. Stay tuned for Part 4, where we tackle lactate dynamics, breaking down hyperlactatemia versus lactic acidosis. Until then, keep learning and keep leveling up. This is Decode Healthcare with Harshal.